Welcome, everyone. It's so good to be here with Palm Beach County Behavioral Health Coalition. I'm Wendy Stephan. I'm the educator and epidemiologist at the Poison Control Center for South Florida. So we're located down here in Miami, and we serve 6 counties, including Palm Beach. So we're so glad to be with you today. So we're going to be talking about overdose prevention, recognition, and response with a focus on opioids, because really that's the most important player right now in terms of substances associated with overdose. So I wanted to start, though, with 2 questions. I want you to think about whether or not you would think to call the Poison Control Center for a drug-related or a medicine-related overdose or mistake. Many people think of us being as primarily pediatric, like for small children, or focusing on chemicals and cleaners. So I want you just to think about, if you had ever thought about the Poison Control Center for helping with that type of, surprise at home. The second question is, what does an opioid overdose look like? If it were happening in front of you, what would you notice about the person? What would be apparent to you? What should you be looking for in terms of symptoms and signs? All right, we'll come back to that one in a moment. All right, our objectives today are pretty clear. We want you to be able to spot an opioid overdose when it's happening and to know what to do. We will also love you to be able to get naloxone for yourself to have so that you can help a family member, a loved one, a friend, or even a stranger who's experiencing overdose. We also want to connect you with the Poison Control Center in terms of how we can help and what role we play in this response process. And then, of course, we want to make sure that you can reach the Poison Control Center as needed by dialing 1-800-222-1222. We're there 24/7, but we'll come back to that. The content for today's program is drawn in part from a program used by Department of Children and Families in Florida. And this is actually a required training for the recipients of funding through DCF. So I want to start with data because I'm an epidemiologist. I can't help myself. But also, this is just such an important topic. And I think sometimes people don't realize how important poisoning is right now. In general, unintentional injury is the leading cause of death of Americans 44 and under. So injuries are very, very important for people in the prime of their life and younger. Of course, after about 44 or 45, you start to see cancer and heart disease taking more lives. But injury is a really important cause of death for Americans. And then this chart actually shows you injury deaths sort of broken down by the types of injuries and by age group. So this is an important chart. So this is data from 2022, which is our most recent that we have national data. It takes a little while to get all of that data cleaned and put together. And so I wanted to draw your attention to the upper right corner. And that shows you that unintentional or accidental poisoning is the number 1 cause of injury death in the United States for all ages together. This is often very surprising to people. When I ask this question to the public, they often think that, the most common injury death is going to be motor vehicle accidents. Those happen in public. Everybody sees it happening. There are flashing lights. People will talk about it. If somebody is in their family dies by a car accident, they generally won't hesitate to describe what happened. That's not always the case for poisoning. And so I think this is very interesting. And I also want to point out sort of which age groups that unintentional poisoning is primarily affecting in terms of leading to deaths. So it's really our 25 through 64 age group. And then to a lesser extent, our 15 to 24 age groups. So this can be very surprising because people think of poisoning and small children. But these days, you can, in our small child population, we see more suffocations, drownings, and motor vehicle accidents causing deaths today. In Florida, we see a very similar pattern. So this is from Florida Health Charts, which is a great resource if you're interested in learning more about injury death in Florida. But you can see that drug poisoning far and away surpasses falls, motor vehicle accidents, firearm deaths, etc., in our state. And I like how they've broken out drug poisoning in blue at the top there versus non-drug poisoning in yellow down at the bottom. So this really starts to get to, what do I mean by poisoning? What's poisoning these people, right? So you can see that drugs of all types play a really important role in injury death in Florida. So what is going on, right? Again, we're not talking about bleach. We're not talking about household chemicals. We are talking about drugs of different types and medications. So that's more than 90% of our fatal poisonings in the United States do involve these types of substances. And then we look at fatal drug poisonings, over 70% of those involve opioids. Don't worry, I'm going to define that term. And then oftentimes our fatalities will involve multiple different drugs, opioids, or alcohol also involved. So when we look at deaths, really, we have to address drugs derived from opium. So I've used this term a bunch of times. So here's this beautiful opium poppy on the right. And this flower actually was discovered, thousands of years ago to contain a substance that our bodies react to. And we're going to talk about why. But so basically what's happening is that, let's see if I can point it out. Here's the seed pod. When the seed pod is scored, a black tarry substance comes out that can be scraped away and further refined into a drug that goes into different forms. Historically, it was opium, but we also see morphine and codeine, which are natural forms of opioids. And more recently now, we see synthetic or semi-synthetic forms, including heroin, hydrocodone, oxycodone, and fentanyl. So these are all derived originally from substances that were discovered in this particular poppy. And so we do still call them opioids. So why are these used, right? We've discovered this a long time ago. The most important thing that we use opioids for in medicine is for controlling pain. So it's very powerful, very useful in medicine for controlling pain. And that might be from an injury, that might be during surgery, etc. So very, very useful from a medical perspective. But these drugs can also lead to a sense of euphoria, relaxation, or intoxication, right? So you can hear the word toxic right in there, that it alters people's perceptions. And for some, that involves a sense of high or euphoria. But the downside of these drugs is that these can be highly addictive, and they lead to tolerance over time. So even if someone starts out using a certain amount and gets a certain effect, over time, they will need more and more of the drug to get back to that original euphoria or sense of relaxation and pleasure. The concern in general for overdose is that these drugs cause central nervous system depression. If you think of your nervous system as having a volume knob, these turn it down, which is really important for pain, for anxiety, and just being able to conduct surgery, for instance. But think of the volume knob again. If you turn that knob all the way down, it turns the body off. And the way that happens is that the breathing stops. When your breathing stops, your heart rate also slows, and eventually the person will suffer heart attack and death. So these are all very important considerations when an opioid is prescribed by a doctor or when someone is using without a prescription. Now I'm showing this super complex diagram, but don't be intimidated. What's interesting is that we have receptors in our nervous system, actually throughout our nervous system, for opioids, which is so interesting. And it comes out that our bodies actually create what we call endogenous opioids. So these are chemicals that actually create a little sense of euphoria and natural pain relief. This comes in handy when you have a very serious injury, for instance, and you need to survive. You need to maybe get help, or for instance, during childbirth. So we have these receptors throughout our bodies. In the diagram, you see them as kind of these squiggly blue lines. And you see the opioid molecule here, the little hexagon, fitting into that receptor. And then triggers a whole cascade of chemical and neurobiological activity that leads to slowed breathing, sleepiness, in some cases, constipation, nausea, vomiting, right? For those of us who are intolerant to it, pain tolerance, of course, and also this sense of euphoria or with, sort of a sense of relaxation. Okay. So very, very powerful tool for medicine with some substantial risks. Sometimes people will think, this doesn't have anything to do with me. Like I don't have opioids in my home. I'm not a drug abuser, so I will never encounter an opioid. And that's just not true, right? So I would say that opioids can be hiding in either prescription medications, that may come into your home, and you may not realize that the contents are similar to something like heroin, right? So codeine, for instance, is a cough syrup, and that's Tylenol 3. It's a brand name. It contains acetaminophen, which is the generic name for Tylenol, but also has an opioid in it. Another example would be Vicodin, which could be prescribed, say, after wisdom teeth removal, which also contains acetaminophen, again, and hydrocodone, so an opioid. Percocet, its active ingredient is oxycodone. You might also have heard of the term OxyContin, right? Would be the other brand name for that particular drug without the acetaminophen component. And then we also have drugs used to treat addiction that in themselves have opioid-like substances. So methadone and buprenorphine are both used to treat addiction, but still contain opioids. So what are our prevention strategies, right? We know that there's not one size fits all. So ideally, of course, we want to prevent substance abuse or use. And so that means a lot of limiting access, right? So there are rules about how we access opioids, right? In terms of prescriptions. In our communities, we may want to make sure people aren't doctor shopping, say taking the same prescription to multiple different pharmacies. And in Florida, we have a prescription drug monitoring program that helps prevent that type of misuse of a prescription. So we also do education in the schools, for instance, talking to young people about not using drugs to cope with stress. So those are what we say are primary prevention strategies. Then the second sort of wave of prevention would be harm reduction, which means that someone is engaging in something risky, but we want to keep them as safe as possible, right? We've failed to prevent the use entirely, but we want to keep them alive, right? And then tertiary prevention would be, all right, someone has developed an addiction or dependency on opioids. They're heavy users. We would like to transition them away from that use safely and effectively using some sort of medication-assisted therapy or MAT. All of these together go together to bring down deaths. So I use the term harm reduction. Harm reduction is basically defined as strategies aimed at reducing the negative consequences of an inherently dangerous activity. So I would argue that seatbelts, sunscreen, and fire extinguishers are all examples of the principle of harm reduction, right? Getting in a car in South Florida, particularly, inherently dangerous, right? But having a seatbelt on reduces your likelihood of dying. Okay. When we talk about opioid overdose prevention, harm reduction tends to involve naloxone, which you see here, otherwise known as Narcan, medication-assisted therapy, or MAT, and needle exchange programs to help keep people who are using drugs alive so that they can at some point recover. So there are certain circumstances where an overdose is more likely, right? So even among people who use drugs regularly, there are certain situations that increases their risk of an overdose. The first is mixing drugs. What we're seeing right now is that fentanyl, for instance, is combined in places that people wouldn't necessarily think it would belong. So, for instance, with cocaine. This can also happen when an individual separately takes different drugs and combines them. And for the medical examiner, it can be very difficult to tell if those two drugs were co-ingested or one was contaminated with the other substance. That's very difficult to tell after the fact. Another dangerous situation is just the potency of the drugs have changed. So, for instance, if you have somebody, who is new to the drug market, for instance, and the first thing they encounter is a pill laced with fentanyl, they are at very, very high risk because they have no tolerance at all. Which brings us to the third. People whose tolerance has dropped. So, for instance, people returning to the community from incarceration are at 30 times the risk of overdosing in the first 2 weeks when they've rejoined their civilian life, right? Maybe they started out with a drug use practice, substance use disorder, but their tolerance reduced while they were incarcerated. Now they're returning to the same drug market, these high potency drugs, back in, old friends or, the same social circle, etc. It can be very, very dangerous for them because it's easy to fall back into old habits that are now dangerous for the person. And the last sort of example here is when people use alone, right? And the strategies I'm going to be sharing with you doesn't change that, right? So if there's no bystander to assist with naloxone, that person using alone is still at increased risk of death, right? So this is why we see sort of single people, people who live alone, people who go off into an area that's hidden, like a bathroom, a stairwell, etc. If they are in trouble, they can be, they can die without someone recognizing what's happening. All right. So going back to the question I asked you at the beginning, I want you to take a moment and you can put this in the chat. What do you think you're going to see if someone is overdosing from opioids? What would you observe if a person was right in front of you? Give you just a moment. This is such an important question because if we cannot recognize it when it's happening, it reduces the likelihood of our being able to take action. And we have a fairly narrow window, right? If somebody does in fact overdose, we have probably 7 to maybe 10 minutes to react to save their life. All right. So I'm going to go ahead and give you the answer. And I'd love to say, first and foremost, that movies and TV are really terrible for helping us recognize an opioid overdose. Okay, so the first thing we typically notice about someone who's experiencing a life-threatening overdose is that they are going to go down. They are going to collapse and they are going to be unresponsive. So you say their name, you shake them, hey, buddy, are you okay? No response, right? And so the place that they're non-responsive might also help you understand what's going on. So again, a stairwell, a bathroom, somewhere that's kind of hidden or out of the way. If it's a loved one, that might be a bedroom, but on the floor, not in their bed, right? These are all things that would indicate this person is in distress. This is not, curled up for a nap. Other signs that this person is overdosing would be that their skin is pale, their lips and skin can be bluish, and their nail beds, for instance, and inside of the lip may be noticeably blue. For people with darker skin, it's described more as being less sort of on the blue, more on an ashy or even a green undertone, because the warm rush of blood and oxygen has faded away. And so you see just a very unnatural color. Okay? Likely they will not be breathing or their breaths will be very shallow. If you know how to take someone's heartbeat, you can go ahead and test them. And if their heartbeat is less than 10 per minute, we would consider that in distress. And finally, if you feel comfortable touching the person, you can lift the eyelid and take a look at their pupil. A pinpoint pupil is one that is tightly contracted not blown big, but shrunken down into a tiny pinpoint. That is a classic sign of an opioid overdose. So, what you typically see in the movies, which is going to be seizures, foaming at the mouth, thrashing around, like obvious medical distress, is atypical for an opioid overdose. Can you see how someone might miss this, right? It could look a lot like sleep if someone is not paying attention. So there are a few things we want to say right off the bat to not do. And these are things we see at the Poison Center and in our ED. When someone has experienced an overdose, people do panic. Sometimes they'll put them into a cold shower, into ice water, to try to shock them awake, essentially. But remember what opioids are so good at doing: anesthesia, right? So things that are painful are not going to necessarily wake the person up. They may want to induce vomiting, right? But if a person is already not breathing, those receptors are already engaged with those opioid molecules, and the effects are already in force. Again, punching, kicking, again, trying to wake that person up, startle them awake. Remember, they're deeply, deeply anesthetized, so this will not help. Sometimes we see people giving what they think might be an antidote. So milk, caffeine, other drugs that are stimulants like cocaine. But remember, an opioid molecule is fit into that receptor and is not going to be dislodged by something like a cup of coffee or a glass of milk. The most dangerous thing someone can do when they encounter someone who is exhibiting these signs would be to try to let them sleep it off, because they're not going to sleep, right? They're actually falling slowly toward not breathing and dying. And again, is someone going to be sitting with them, monitoring their breathing? Probably not. So you'll really need to get that person to care. So our steps to responding to an overdose are to first try to wake the person up, right? If you can get them awake, if you can get them speaking, maybe you can find out what's happening, right? Maybe they're not experiencing an overdose. Maybe they can tell you, I'm a diabetic, or this is what's happening to me. I have a terrible headache, whatever. They can give you some information. So that's the first. You want to call 911 as soon as you recognize a person is in medical distress. And then if you have naloxone, you can add the naloxone to the person. I'll show you how. And then attempt rescue breathing if you want. So here's one way to check responsiveness, and this is called a sternal rub. Your sternum is right here between your nipples, your breastbone. It's the hard bone here, just covered by some skin. So you want the person to be on the back, like you see in the photo, on a nice hard surface. You can say their name. That might help wake them up. And then if you don't get a response, you can use your knuckles to rub firmly between the person's nipples, just the way you see here in the photo, right? This does not damage the person, but is very startling and uncomfortable and should wake a person up who is just sleeping or drunk or something like that. Okay. If you do not get a response from a sternal rub, that is, again, another sign that you need to call rescue right away. So if you have naloxone, you can give it. So it's also called Narcan. That's one of the brand names. It is now available over the counter, which is a big change and what we think is very positive in terms of getting this into more people's hands where they can reverse overdoses. So in the past, it used to be given mainly by injection, but the version that is available to the public is a nasal spray. So very easy, very straightforward, doesn't have to involve any injection or anything now. The effects kick in 2 to 3 minutes. And what do I mean by effects? I mean, the person will start breathing again, right? You'll actually hear them draw breath and their color will improve, etc. Maybe they'll vomit, right? Because their body is reacting to the presence of the antidote. That protection that the antidote provides only lasts 30 to 90 minutes. So we do still recommend that rescue still comes, they transport the person, and they get some sort of medical, review and support. To be clear, this naloxone is not the same as the medicines we use to treat addiction in medication-assisted therapy. Those are drugs like buprenorphine, or otherwise known as Suboxone. These are different drugs. These are more maintenance drugs. This is what we call a Lazarus drug, a bystander drug, an opioid overdose reversal medication. So we have a long history with this drug. We know how to use it. It's very safe, and it is called an opioid antagonist. Basically, it fights opioids in the body. And here's a very simplified diagram of what's happening. Remember the squiggly blue line receptor. Here's the receptor in the nervous system. The opioid molecule fits nicely into it and triggers all of these effects, whether wanted or unwanted. Naloxone fits more tightly on the receptor and essentially displaces the opioid, allowing breathing to restart. So what are the effects of naloxone? Well, here's the thing we're looking for, which is that increased breathing and heart rate to keep the person alive. These are other symptoms that can come along with the use of naloxone, particularly for people who are heavy and regular users of opioids. What you're doing is essentially putting them into withdrawal. So you may see people suddenly experience exhaustion. They may lose bladder or bowel function. They may appear to have a fever or sweat. They may vomit. They might be disoriented or confused about where they are or what's happening. And they may complain of pain. Any pain that was being masked by the use of the opioid will, of course, be revealed, right? So it's not necessarily a pleasant experience, particularly for someone who is a heavy or regular opioid user. But what they will be is alive, right? And that's the focus of what this intervention is really keeping the person alive. So there's the applicator. You can see how easy it is. It's a one-time use. That's it. You're going to go ahead and spray it right up the nose on one side. And this is a 4 milligram or 0.1 milliliter dose. And if you feel comfortable while you're waiting for rescue after having given the naloxone, you can do rescue breathing while you wait. You also want to put the person into what's called recovery position. Remember, we already moved that person onto a hard surface, right? Because if someone is going to do chest compressions, whether it's you or if somebody comes to do CPR, you don't want them on a bouncy bed or a soft couch, right? A nice firm surface is best. And while you're waiting, you're going to put them to their side slightly. You see the hand tucked under the face. This prevents them from rolling onto their face, and the knee drawn slightly up, again, to prevent rolling forward. All of this is aimed toward protecting the person's airway if they do, in fact, vomit while they are waiting for rescue. You do not want it going back down, and you don't want their face pressed to the ground. So I mentioned fentanyl earlier in the talk. Fentanyl is an extremely concentrated form of opioid. They estimate it's between 50 and 100 times the strength of morphine. And so very, very concentrated. It's very easy to synthesize this form and to traffic in it. You can move a very small amount of it and then cut it with other agents to form counterfeit pills, sprinkle into cocaine, etc. So don't worry about overdose or danger to first responders and police and family members simply by touching fentanyl or being close to someone who has taken it. The concern really is for the person who has consumed it, right? And what's shown here in this image is what is a potentially fatal dose for someone who has no tolerance to opioids. So that is a new user, that might be a teen, somebody like me who really, I have no tolerance to opioids whatsoever. It really wouldn't take much to tip me into a potentially fatal overdose. So we estimate about 2.4 milligrams. Naloxone will work for fentanyl, but it may take a little bit longer to work, and you may need to use the second applicator in the box. There are some myths about naloxone that may interfere with people's willingness or interest in using it or carrying it. The first is sort of a sense that by offering naloxone, by carrying naloxone, that you somehow endorse or encourage drug use. This, I think, is not factually supported in terms of communities where Narcan is more available. We actually see fewer deaths. We don't see an increase in drug use at baseline. Again, think about it a bit like a seatbelt. People aren't necessarily encouraged to speed more because they are wearing a seatbelt, right? There's not necessarily a connection between those two. Second myth, I would say, was, well, if you can just revive somebody with naloxone, well, maybe they won't seek treatment. There doesn't seem to be any evidence for that. And in fact, anecdotally, people who are revived do frequently describe it as a second chance or a sign that they really need to get help, right? That they can't go into recovery if they're dead, right? And that's sort of the most important thing here, is to keep people alive. And then the final misunderstanding is, well, if I reverse an overdose, then we're done and everything's fine and we can go on with their days and we're done with, with rescue. Hooray. But remember, this only gives you a window of 30 to 90 minutes of protection from that opioid. If the person has been exposed to fentanyl, for instance, it's very, very strong. So they could actually drop back into an overdose state after the naloxone wears off, essentially. So it is important to continue to get that person to treatment, to care. In Florida, we have a Good Samaritan Act. So it's very important. People need to understand that if they do get help, if somebody experiences an overdose or they get help for someone's experiencing an overdose, they are not going to be charged, prosecuted, or penalized for possession of the controlled substances. This is a very important message for really everybody, but particularly young people who might really panic if they have a friend who is exhibiting signs of an overdose. We do see very tragic cases where kids will actually abandon a friend in panic because they realize that they've used drugs and are sick. So who needs naloxone? I think you could argue that it's a good idea for anyone to carry it. I carry it in my handbag. We do want people sprinkled throughout the community who just have it on hand in case. But in terms of saving the most lives, there are a few groups of people who we really want to focus on getting naloxone. First are people who use drugs and or are surrounded by other people who use drugs, because they're going to be present most likely if somebody goes into distress. So that's a little bit, it seems a little surprising, but we want to put naloxone in the hands of people who are current users. So our needle exchange programs do offer naloxone to their participants, and we know that they are the most likely people to be able to respond to an overdose in that community. So, just in terms of likelihoods of experiencing an overdose or being near to someone experiencing an overdose, that's about a 10 times increased likelihood for people in that community. And then we also know that people who use drugs or who are in recovery are likely to know people who are still using or who are still at risk. So again, another great audience, get people, put it in their hands and have them share it with people who may need it. And then finally, family members, partners, loved ones, or roommates of people who are users of drugs or who are in recovery where their recovery may be fragile. So again, that's amazing now that it's over the counter, so that a family member could purchase naloxone or obtain it to have it on hand just in case. So how do I get naloxone? Well, the amazing thing now is, again, it is available over the counter without a prescription. And I've seen it at CVS, at Publix pharmacies, and at Walgreens pharmacies in our communities. The bad news about this is that it's pretty expensive, right? So it's about between $45 and $50. So to me, that seems like a lot. Love to see the price come down. But that is one option. It's just walking into a pharmacy and purchasing it for yourself. There are plenty of people who do that. But if you want other options, you can contact South Florida Opioid Alliance. I have the phone number here. Or you can contact the Palm Beach County Behavioral Health Coalition. They also provide naloxone. And if you don't have contacts with either of those folks and you'd rather use a website, you can go to the isavefl.com website. Go to the Find Naloxone tab, select your county, and look for your DCF partner to pick up your naloxone, again, for free. So there are good options for getting it for free. It's very stable. It doesn't expire very quickly. I think you have about 3 years. And so this is a really nice sort of add-on to your first aid kit for people willing to carry it. Okay, this is what the isavefl.com website looks like. And again, there's the Find Naloxone tab right there. And there's a lot of the same information that I've provided to you today is available on this website if you wanted to share it with anyone else. All right. And then, of course, there's the Poison Helpline. So we're here 24 hours, 7 days a week, answering calls about all types of poisonings, including those from drugs, whether it's legal or illegal. Doesn't matter to us. And this is a national service. So wherever you are in the United States, you can get help right away for free, confidentially. And then the data from this hotline is uploaded into the National Poison Data System, which is a very powerful tool for public health in the United States. So we can see in real time what's happening to whom, so that we can respond. So just to clarify, if someone has taken the wrong medicine, if someone has taken too much medicine, if you need help giving naloxone, or if you have a question about mixing drugs, or if you're worried about a drug side effect or interaction, you can call the 1-800-222-1222 number. And here are my references, and I'm happy to take any questions now. Thank you so much for your attention.
Well, Wendy, thank you so much. I think there's a handful of questions out there for this. One of the questions that comes in off the top of my mind is, there's so many different doses of Narcan, whether it's 3 or 4. I think there's even a 10 millimeter now. So is there a difference in what you should use, what you should ask for, or is it just one of those you don't get enough, you should try again?
So great question. So I'm most familiar with the packaging that I showed you, the brand name Narcan and the 4 milligrams. That's what I'm finding is just most available to people in the community. There was a stronger form that is available for the public. I'm blanking on the name right now. It starts with a Z. Anyway, that's the 8 milligram. But what we heard back from people who were using these reversal techniques, and particularly people who in the harm reduction world, so that people who are regular drug users, right, who have saved a friend or family member, they had complaints about the 8 milligrams, simply that it was inhumane, I think is the word they used, in the sense that it was forcing people who were heavy users into a very fast and very steep withdrawal. So essentially that the experience for them was really unpleasant. Oh, Kloxxado, thank you so much. I was blanking. I was picturing a Z. It should have been Z X's. Yeah, so the feedback that we heard about Kloxxado was simply that it was a really, really unpleasant, miserable experience for people. And there is a very, very small risk that when you have someone who is a heavy user and they get a high dose of naloxone, that we can see some cardiac effects in those very, very rare cases. We don't see it often, and that's why in general, I feel a little more comfortable, giving out the 4 milligram. But again, you may need to use both doses of 4, but essentially you're spreading it out, essentially to make that withdrawal somewhat slower and less like dramatic, just to protect the heart. But again, we don't see those very often. It's just a potential concern.
So if you were to administer that second dose, I think I saw in the notes that it would take about 2, 3 minutes for the first one to potentially kick in. So you
Yeah.
want to wait about 3 minutes before
Yep.
you try the second dose?
Yeah,
Okay.
typically, because there were questions like, well, why don't we just do double barrels, up both
Correct.
nostrils, like, because that's essentially the effect of a Kloxxado. But we're saying is for many people, the 4 milligrams, the single dose will be enough. So particularly, the teen or a new user or someone who's just mixed up their medications, right? This could be someone who's actually taking prescription opioids. Maybe they double dose by mistake. That would be probably sufficient for them. It's going to be more complex for someone who's a heavy user. But
Gotcha. And
great
I really
question.
appreciate that you talked a little bit about when somebody comes up on a scene, what to do, what you observe, but to not be afraid to touch the victim, if you will, that
Yes.
it's not transferred the fentanyl through touch.
Yes. So that there was a lot of misinformation out there, and that dates back all the way to about 2015, where there were some assumptions made about, okay, it's a lot stronger, so then it must mean that just, particles in the air could be a problem, or touching, skin absorption. But keep in mind that it took many years of pharmaceutical development to develop the fentanyl patch, which you may be familiar with, right? That's used for people who are, either terminally ill or dealing with cancer pain. It was actually pretty complex to get fentanyl through the skin. And so it's not something that is going to just be incidentally, absorbed.
I know we had one question come in, and if you want, go ahead and open it up for we could see everybody, just in case I don't get Sergeant Pierce's question in all together. But his question was, what is your relationship with local coalitions and with the DEA Operation Engage, if any?
Oh, so we really appreciate the resources that DEA Operation Engage has provided. So if somebody's looking for a curriculum, for instance, where they want to do in-school things, we do recommend some of the things that they've developed jointly with Discovery Health, really, really high quality curriculum. So that's great. We also partner with DEA at a lot of our events. So we've done school events in partnership with them, et cetera. But again, we're not very closely related because we encounter, concerns about people calling the Poison Center because they think we're part of law enforcement. And we're not. So, I love to partner with them, but I also want to be very clear. If you call us and say, hey, I just did this illegal thing with this illegal drug with my friend's, medicines, that our role is not to get involved on that part. We're healthcare providers, we're HIPAA compliant, so we don't break confidentiality unless, very, very high standard is met. So yeah, and then our coalitions, I love to attend and provide data, right? Our poison centers have a lot of local data down to the zip code level, so we can tell you the types of calls we're receiving. Obviously not breaking confidentiality again, but giving trends and that type of thing.
Absolutely. Well, I definitely appreciate the distinction because, again, so many people are just so afraid to pick up the phone because what's going to be the consequence for them. And that's why you have the Good Samaritan law. And that's why we're a different type of agency like you. It's all about helping the individual, not about trying to call the police.
And I would say that's a reasonable concern. I think there, especially this program, the content came from DCF. We also keep a little bit of separation there because the content has been great, but you don't see us partnering at events and things with them because again, we don't want parents to feel like they're going to be turned over to whatever, because that again, not our role at all.
That's important. Okay, so as we've opened this up with all the participants that are here today, please raise your hand. You're welcome to unmute, ask the question directly. I know, you said it during the presentation, but that common thing that always comes up, no matter how much you hear about naloxone or Narcan, is that, is it hurtful and the long-term effects, and from what I understand, that there's not any long-term effects that I've heard or seen of, but it's still the best, you're really your best remedy for that situation.
Yeah, so we're unaware of sort of, if somebody experiences a reversal multiple times, certainly in the ED, they use naloxone very frequently and, they will use it on the same people, right? There are many people who, go through a period of really dangerous drug use and have to be revived multiple times. I am unaware of long-term effects from having it used over and over. So that I can't speak to necessarily, but, and certainly the short-term effect is that they are still breathing, and that's really the goal. So
So, a couple follow-up questions. I think Sergeant Pierce, back to you. Is a simple message we provide to youth as part of our drug awareness presentations during the Good Samaritan Act. If you witness an alcohol or other drug overdose, don't run, call 911. So, thank you for sharing that.
Yes, excellent.
And Kristen Parrish asked, do you provide information to people about the 911 Good Samaritan Act to help
Yes.
encourage them to call 911?
Absolutely. So in these presentations, we provide this exact presentation to all the DCF funded programs and actually anyone who asks for it. So just invite me, I'll come do it. But we've also included this in all of the programs that we're doing in conjunction with South Florida Opioid Alliance and the Fentanyl Fathers in the schools, to the middle schools right now. We're going into every middle school in Miami-Dade County and having the conversation about not running away. And kids really do want to do the right thing. They want to help each other. And now that they've had a conversation and they've seen it in public, their teachers are there, their SRO is there. There is an acceptance, I think, a increased level of comfort for getting help.
And I know a story that we had in Broward County that a student, they had a presentation, they learned, they didn't run, they called 911, they got there quick enough. And, the report really is that if, you weren't there, if you waited any longer, you bring a life. It's even if you didn't administer the Narcan, it's the fact that you made the phone call.
Exactly. So we say whether or not you have it, you don't need that. But it is important, I think, we face a common assumption that particularly just with all poisons, that essentially you have contact with the poison and you die. Like that is just not the truth, like across the board. We have many, many tools, antidotes, antivenoms that, we have time to engage, we have time to respond. So please call, and we can sort of walk you through what to do, whether you have naloxone or not. But at least you're not just abandoning. I would put in the caveat, the Florida Good Samaritan law, to be clear, does not protect people who are trafficking the drugs, right? Mm-hmm. So if they show up and there's somebody who's overdosing, but it's in the middle of obviously a drug lab or something, an illicit drug lab or a trafficking, organization, that is not the same. So, gotcha. Different states have different approaches to the Good Samaritan law, but ours specifically carves out trafficking.
That's good to know. Trish, thank you for sharing. She said, FYI, Manatee County's overdose prevention and education plan offers free training and Narcan. So we have a chat for that. So if you're in that Manatee area, we can put that in the chat for everybody to see. And that I say Florida is a great resource. You could see all the different agencies in different counties, like our agency, and we don't ask names. We don't care who's taking the Narcan. We report how many we gave out, and that's it. And the hardest part is reporting when they're used. So if you have an occasion that you used it, again, there's no questions that people ask. They just want to know, did you use it to try to help somebody, or rather than it expiring. So,
and you're not going to be like obligated to sign up for services or anything, because that was my first question. Like, you're encountering this organization that provides other services. Are they now going to add you to their mailing list? Are they going to want you to sign up for stuff? And I've been assured that that's not the case.
Oh, absolutely. And for us, if you're here locally in Palm Beach County, you can just email us prevention@pbcbhc.org, and then we can set up a time to meet with you and kind of get you that. But again, we try to, it's just easy and convenient is what we're going for. Other thoughts, questions? I'm looking around the chats to see if I missed anybody. Well, yeah, there's lots of questions, and that's the funny thing is the more you talk about where to put it, so many people, I used to say in a college campus, the likelihood of using an AED is so much lower than using an opioid, right? Or for a Narcan reversal. It's just crazy to me. But the perception of having it there is what so many people I think you're fighting. It's that stigma. But the nice thing is that first responders often carrying it. Good question was, airlines, what do they do midair? And
I don't know the answer to that yet. My understanding, because airlines are governed under federal law, that there requires actually legislation to get it added. There's a special law about what can be carried on an airplane. So I carry it on airplanes when I go. I always make sure that I have it, and I actually have offered it at one point when someone was found unresponsive on a plane. It was a really good feeling to stand up and just let them know, because there was a physician on board who was attending the person. Just I was able to say, I have Narcan if you need it. It was a really good feeling. So I don't know that the law has been updated since Narcan was, or naloxone was made, over the counter. I think
And I
it's
know it's
pretty
one of those
recent.
big gray areas because, like I said, what state you're in, what law governs you. And my cousin's a pilot for a major airline, and I ask him all the time, and he's like, I carry it, but that's as much as I can say.
Well, things that are federal move very slow. So, right, that in general, it would, like I said, it's going to take legislation, and I really don't know where that process is.
That's true. Other questions, thoughts? One, and perfect. Let's see. So thank you for covering so much that doesn't need to be talked about. It is truly appreciated. My question is okay. Provide people. If you provide people information about fentanyl test strips and how to access harm reduction organizations, is that something that you provide?
I do. I do work with some harm reduction organizations, but we haven't carried test strips yet. I know South Florida Opioid Alliance has it. I know it was made legal in Florida, so that's a plus. I'm kind of on the fence about it just because it does require the destruction of the drug to test it. And so I've heard some resistance from people who are like, listen, you end up having to destroy the drugs that people have gone to great lengths to get. And then with fentanyl, particularly with the counterfeit pills, if one tests safe, there's no guarantee that the next tablet, even in the same batch or the same baggie, is going to be safe. So I would say it's better than nothing, but I'm not to the point yet where I'm carrying it and recommending it. So
No, that makes sense. Sergeant Pierce asked your counties. What counties do you cover? Are you all over the state, or do you have other counterparts in different parts?
yeah, so poison centers are national. There are 54 poison centers around the country. We recently lost one in Puerto Rico. We're down from 55. So that's sort of a scan, trying to get that coverage back up. I think New York City has taken over in the short term. My counties are the 6 counties of South Florida. So Palm Beach County, all the way down to the Keys, all the way over to Collier and Lee counties are covered by me. I have colleagues in the Tampa Poison Control Center and in the Jacksonville Poison Control Center. So you can go to our website, which is floridapoisoncontrol.org, and that will show you sort of the map of where you are in the state and what poison center serves you. But there are similar, not this exact presentation necessarily, but something very similar, and resources are available to you there. Also, some really nice downloadable PDFs and things on preventing opioid deaths. We have a really nice flyer that I know South Florida Opioid Alliance gives out when they are providing naloxone, right? Because we want to prevent in general by keeping things out of reach. We want to respond with naloxone if necessary, but we also want to get people into treatment who have an ongoing issue.
Gotcha. I mean, and I would imagine just kind of it's one of those, it's a tough conversation or topic, if you will, that you almost want to end on a positive note, that the trends are trending in the right direction, that the word gets out there about prevention and the prevention works. It's just that everybody kind of doing what they can do. And I'm assuming you're seeing hopefully fewer calls regarding this.
Well, yeah. So, and I also think that I really noticed that there's a lot of anxiety around the issue. And as you mentioned, stigma, right? But when we talk about caring for each other, we have a focus of saving lives, that it's interesting to see how quickly everybody comes around, because every once in a while we still get kind of like political, commentary about like, oh, this should happen and that should happen. And why hasn't that been done and whatever. And I'm like, my goal here today is to keep our loved ones, who I'm implying could be drug users, right? Like those are our members of our community. Those are people we care about. These are classmates, colleagues, right? Community members. Like just framing it like that, I feel like already is really important. And I can see, like when we're in the schools, that it's kind of the first time that these students have ever heard about a drug user mentioned in the context of someone we care about, someone we love, someone we want to protect and support. It's just a very different perspective. And so I think bringing that aside even from naloxone, aside from the signs of overdose, we're simply talking about, saving lives and that we have an obligation to each other. That already is just, I think, important. So the more we do that, the better. And I think that will sort of hopefully over time reduce stigma and get people the help they need.
Absolutely. I mean, putting a face with that, and that's again, the hardest thing I think working in the field of prevention is those success stories. And this gives us that opportunity to have the success story, to have the conversation tomorrow, to have that process of recovery. So,
and it takes such courage for the families to come forward. And we are seeing more families who have had reversals, but also people who have lost loved ones coming forward and saying, and it requires tremendous bravery, right? Because there's so much blame and shame associated with these deaths, but they're coming forward and they're saying, I don't want this to happen to you. And I just think it requires incredible courage and strength. And I have a lot of admiration for folks who are able to do that, because it's also an important, constituency in this discussion.
Well, again, I really appreciate your time today. And for those of you watching, or, if you need resources, you can contact us. And if you forget anything else, you can always go to isaveflorida.com. We'll make sure that we send out some information. Everybody that's registered for any of the webinars you've attended, we're going to go ahead and send you a survey. There's this thing, areas for improvement. We're looking for to provide linkages to care. And then also we're going to provide a link to the recordings that we've had in case you've missed some of our other speakers, whether it was emerging issues with Ellen Snelling. Fentanyl Fathers was fantastic, talking about the work that they've done and really what Allies in Recovery is doing with CRAFT to work with families to empower them and how to work with somebody that's a loved one with addiction. So, and really when you look at the whole thing, it's everything is so interconnected. So Wendy, thank you for being here. Everybody who takes the time to join us, thanks for what you do and thanks for taking the time. And if you have questions, please don't be a stranger and reach out.